Good evening, everybody, the respected chairpersons, and my colleagues. I must thank the organizers for inviting me to speak on a topic which is very close to my heart. Ladies and gentlemen, boys and girls, welcome aboard the flight number 1549 of United States Airlines. We have just left the New York airport and is at 28,000 feet high from the sea level. And we are crossing the Hudson River and will be reaching our destination in next 45 minutes. It was 15th of January 2009 when this announcement was made by the air hostess, but the plane never reached the destination. And the reason behind it was the population explosion. Population of not the human beings, but you can see the Canada geese. The Canada geese, these birds, they migrate, and when they migrate, they usually form a V line of single, birds, and they cross the sky. And these being the endangered species, it was declared that Schedule 1, they are under Schedule 1, which means they cannot be killed, they cannot be hunted, or they cannot be captured. So they went on reproducing, they went on proliferating in a manner so that they filled up the sky one day. And when this flight 1549 was flying, it just hit the flight. Both of the engines were destroyed, and Sally Salenker, who was the captain of this pilot of this flight, had to take down the plane, and they landed in Hudson River. On board was 155 passengers. Luckily, all of them could be saved, but it cannot be so. Not in all flights which lands in a river or somewhere else can be saved. So this Sally became the national hero, and the film came on Tom Hanks' Sally. All of us probably have seen it, but it's not so. It must make us scary feeling. What is actually going on? Today, when I was coming to this hotel, I took a picture in my cell phone. Delhi, today, 10th of November 2018. No religious festival is there. There is no political rally. Even then you can see people cannot walk on the road, and population explosion is still there. Causes of population explosion are only 3 in number. Very easy. Increased life expectancy. Number 2 is decreased infant mortality. And third is increased birth rate. Now, basically, none of us will want to interfere, number 1 or number 2. We would like to increase our life expectancy. We would like to decrease infant mortality. Thus, only remains the third point. So, decreasing the birth rate can only decrease this population explosion. And you will be surprised to know that India was the first country in the world who in 1951 introduced National Family Planning Program. Then what happened? Long years have passed. Still today, in India, you can see contraceptive practice is only in the range of 58%, of which majority is female sterilization. Do have a lot of pills which are available, almost 50% of them are available, which are available abroad. We have a lot of other methods, but none of them are very successful here, resulting in unintended pregnancies, where you can see almost half, that is 48%, are unintended pregnancies, resulting in unintended childbirth, which are adding up to our population. We know in 1921, when first Ludwig Haberland, they suggested that ovarian hormones given from outside can prevent pregnancy by acting on the hypothalamo-pituitary-ovarian axis and preventing ovulation. In 1961, Gregory Pincus, he could make the estrogen and progesterone in the laboratory, And the first oral pills were launched in 1965. And how many years have passed till date? It was in 2014. This came up when the pills have become so small, means its composition have decreased, the amount of hormones have decreased, so powerful, so that there is no failure rates, almost zero failure rate, but so misunderstood. So people are not prescribing and people are not taking the pills as it should have been. So both the people are at fault, and resulting in another picture. The last week from Mumbai, there was no religious festival. Again, there was no rally, but there was an interview of the job in the Eastern Railways where these youngsters were going for giving the interviews. World's population is expected to reach 9 billion by 2050, and India accounts for almost one-fifth of the world's populations. The problem is myths and misconceptions. Myths and misconceptions at the level of the users, that is the woman, and myths and misconceptions also of the doctors. Very sad to say, not only from the other faculties, but even some gynecologists are scared to use the hormones for the purpose of contraception. Because this woman, some of them get side effects. They were getting it more so when the doses of estrogen progesterone uses were higher. Even today, 12% get abnormal uterine bleeding, nausea, weight gain, etc. However, when we have decreased the estrogen doses over time from 50 microgram till today, it has come down to 15, even 0 microgram of estrogen, the side effects have decreased. And this is the milestone in the evolution of COC from 1960s when it was first introduced in Europe and Australia. And in 70s, mini pill, only progestins came, and followed by, so that estrogenic side effects are not there. We, as the students, saw the introduction of biphasic and triphasic pills, and 1990s, the amount of estrogen decreased, low dose doses were introduced, 2000, when continuous and extended for 3 months, continuously somebody can use the pills, and 2010, natural estrogens are now being used as estradiol, and also progesterones have changed in these oral pills. Hormonal contraceptives, which we are now using, are not only combined pills, but progesterone-only pills, which we use in breastfeeding mothers or who has got estrogen intolerance. We use long-acting progestogens or estrogens as hormone-containing IUDs, Mirena, for example, the long-acting injection patches, and emergency contraceptives, which become so popular because you have to just pop up one tablet and think that I'm not going to get pregnant, and that caused devastation. And government was so interested in promoting it that all other pills at that point of time was not at all being purchased at the pharmacy level. 2000, the 6th World Congress on Contraception, I personally attended the conference, and we did a trial when in India, the first low-dose pill with desogestrel was introduced in 1999, and we did this trial in 30 centers of India. I was the principal investigator, and we were very scared. We were thinking that 20 microgram pill might cause irregular bleeding in Indian women, and it was proved to be wrong. Indian women probably a bit more have, in fact, maybe for the reason for that, they were not at all bleeding to the level of the European woman. We looked at 3,600 cycles, and we found that no menstrual problem was found in 88% after the end of 1 month and 91% after the end of 3 months. So it became very popular, and we're using desogestrel containing pills till date. And regarding the efficacy, which is very important, there should not be any unwanted pregnancies, and with the proper usage, there was none. It was 0%. A woman forgot to take 2 pills, and 1 user failure was thus reported in this study. At that point of time, venous thromboembolism was a big issue in the prescription of pills, and a lot of trial reports came up, and it was ultimately you can counsel the woman whom you are going to prescribe. that if your woman is not taking contraceptive pills, her chances of having venous thromboembolism is 2 per 10,000 women a year. And using pills, it will become 7 to 10. But when she's pregnant, maybe unwanted pregnancy, it goes up to 29 per 10,000. And immediately after delivery, it goes up to 300 to 400 per 10,000 women. So you can see the risk factor which the woman will fall if she's not using contraception and taking an unintended pregnancy. Of course, when you are using low-dose pill, a 20 microgram one, the chances of arterial thrombosis is much less, or twice as less. The risk of myocardial infarction, ischemic stroke seem to be less, and the strong evidence for the dose-response relationship has been found when ethinyl estradiol is 20 microgram. WHO therefore recommends low-dose pills, as well as the American College on Obs and Gynae says less than 50 microgram low-dose pills are the best with the lowest progestin dose. There are a lot of concerns about the cancer. The woman will say, I will develop cancer. And we can tell if you're using pills, your chances of endometrial cancer is less by 70 to 80%. If you're taking the pills, your chances of ovarian cancer is lessening by 40 to 50%. And also nowadays, the colorectal cancers have been found to be less if you're using it for more than 6 years at a stretch. The Cochrane report results are now we are very interested to see, and here again in the Cochrane, 20 microgram versus more than 20 microgram estrogen combined oral pills for contraception has been found to be 20 microgram theoretically much safer, and medical eligibility criteria has now extended. Now this is from the point of view of the physicians. Till now I was talking about the side effects and concerns about the woman, but now it comes to the physicians. While prescribing till today, a lot of doctors will say, this woman has got high blood pressure, I'm not going to prescribe. This is the woman who has got diabetes, have got family history of breast cancer. So not at all. Now medical eligibility criteria has been published by WHO, depending on who can use OCs and who cannot use OCs. 4 groups have been there. And looking at that, it's very easy. There are some MEC, medical eligibility criteria will, and looking at that, we can very easily say, yes, you can use. And there's a document behind it. You will never be sued if you write accordingly to this MEC will. We must also talk about the non-contraceptive benefits. After usage of so many years, we have come to find that contraceptives are not only contraceptives. They are, you buy one, you get 100 other free. So A, B, C, D are the groups of non-contraceptive benefits, of which related to cycle, group A, cycle is regulated, amount of bleeding is less, there is no dysmenorrhea, no premenstrual tensions, and benign tumors like fibroids, the endometriosis, the pain, the pelvic pain, salpingitis are much less. The benign cysts of the ovaries are less. The painful breasts are less. Cancers I have already discussed, and others, that is decrease in anemia, which is a big problem in India, increased bone mineral density, and decreased acne and hirsutism. These are the benefits we can talk about. What about the progestins? All progestins are not equal. We know there are a host of progestins we're using nowadays. We are looking at the potency. We are looking at the androgenic effect, which we don't want. We are looking at the anti-androgenic effects, which we really, really love to have. Anti-mineralocorticoid effects for the woman who feel bloated before periods, who feel a bit irritated, mood changes are there, they will benefit from the anti-mineralocorticoid effect of the certain progestins, and lowering of the sex hormone binding globulin. So what happens, in some cases when sex hormone binding globulin increases, we get lesser circulating androgens, and androgenic side effects like acne and hirsutism will be less. Progestins, therefore, we divide into 2, older and newer. And in the newer group, desogestrel, which we are using in India since 1999, have given excellent results, not only for contraception, but for various other purposes we're using it. There are other newer progestins also, like Dinoges, drospirenone, and also not progestin, but we're using cyproterone acetate. In 2000, the World Congress in Contraception happened in Slovenia. Slovenia just became independent at that point of time, and therefore its capital Ljubljana was the site where we went for attending this congress. I personally had a paper presented over there, and people, the radio over there and television, they came to me, the media came to me to take an interview from India. A lady doctor has come who is presenting a paper on contraceptive. They were, really they were surprised, and they're telling, don't you find elephants on the road or the snakes hanging from the trees in India? So that was the situation. However, it has changed now. And beautiful city of Ljubljana with all the dragon, everything. So the contraception theme was in the third contraception in the third millennium, re-evolution in reproductive and sexual health. And there, the drospirenone and desogestrel were compared in a big way because Yasmin was a product that was launched over there. And it's a beautiful sight to find Yasmin everywhere, and very beautiful ladies, girls, ladies, and young women's pictures everywhere with a very smooth skin, showing that if you use it, you'll get a very smooth skin. And people started using it like anything. Now, after using it, skin is not only the factor. You have to look at the efficacy of the pill. You have to look at other side effects. What is the bleeding, irregular bleeding rate? And these are over there. These women in the Cochrane review were found to have more chances of breast tenderness. 5 trials with more than 4,000 women are included, and nausea in 6 trials. Cyproterone acetate we are using for anti-androgenic effects, especially in PCOS with hirsutism, has got some effect on the liver, and nowadays it has become a second line of agent and should not be used only for hirsutism treatment. Cochrane review on the progestogens shows that desogestrel, the third generation progestogens we are using for such a long period of time, is the best result. 30 trials with more than 14,000 participants, that less intermenstrual bleeding in this woman using this. This is a very interesting report which shows that what is the effect on the ovarian suppression, which is actually our motto to prevent ovulation. And desogestrel is the best in ovarian suppression, and followed by norgestimate, gestodin, levonorgestrel, a bit dicey. But looking at the triphasic pills, they give very bad result in the ovarian suppression, so chances of pregnancy is much more. If we compare desogestrel with the older one, levonorgestrel, discontinuation rate with the levonorgestrel is much higher because side effects are more. And we don't want a woman whom I have prescribed an OC pill to discontinue it, get pregnant, come back to me, and I get irritated. She goes back to a doctor, to a person who is not at all a doctor, and does an MTP. She gets septic abortion and suffers immensely or dies. I don't want it. Therefore, I want some pill which she should continue because the side effects are less and good effects are more. About the starting the pills, earlier we told that you have to start the pill on the first day of menstruation. So what happened? I used to prescribe, the woman went back, forgot, or somebody else at home said, don't use it, you will have breast cancer. Don't use it, your weight will increase. So my counseling effort gradually decreased, waiting for the first day of the period. So now it is quick start. Whenever the woman coming to you, say you please start the pill today, first 7 days you use condom, and then you continue and you won't get pregnant. So this is a very big change in the profile of the usage of oral pills. And how long? Earlier we knew that our teachers also used to say, use it for 6 months, stop it for some time, let your system come back to the regular pattern, and then again use it. No, use it continuously till 50 years of age. And as the president of the Indian Menopause Society, we always promote in the perimenopausal age, when you get irregular periods, where there is very remote but chances of pregnancy, you are having problems, please take low-dose oral contraceptive pills with less androgenic side effects like desogestrel, which will also give you a good lipid profile. What about the POPs? When we were students, levonorgestrel was used as a progestin-only pills and acting on the cervical mucus, and there were a lot of failure rates. It was in disrepute, but later on when desogestrel was introduced, and only 70 micrograms, 75 microgram is found to give almost 100% protection against ovulation, we were surprised, and it was found that desogestrel is a very strong hypothalamo-pituitary ovarian axis inhibitor. So there is no ovulation, and she goes on taking desogestrel for innumerable days and can go on breastfeeding. I don't have much of a time, probably. Anyway, so this is the trial which I made. I was one of the investigators in this desogestrel-only contraceptive pill, Cerazette, and that was done in the Indian woman, came up in the Indian Medical Association. It showed very good result regarding the patient satisfaction, physician satisfaction, the bleeding pattern. Almost 40% became amenorrheic after 3 months period of usage. Adverse effects were much less. The headache and breast tenderness were the noted adverse effects. And changes in the body weight was remarkably less when she was using low-dose progesterone-only pills with desogestrel. About the Pearl index, when we compare, it should be 0.2 to 1, 0.2 to 2, or according to WHO, desogestrel is in that range. Drospirenone 3 milligram is in that range, but when it is decreased, histidine ethinylestradiol 20 microgram, the results is far, far less. If we compare 20 microgram ethinylestradiol and 30 microgram ethinylestradiol containing desogestrel pills, both of them got no difference in the Pearl index. Both are because desogestrel is giving the hypothalamo-pituitary axis suppression. And in this, both the pills, 150 microgram are there. So that result is fine. Estrogen only controls the cycle. So we start with 20 microgram, and if the woman gets, even after 3 months, irregular period, we can change over to 30 microgram. Now, this is the last thing we must be knowing about desogestrel. It is being used for in PCOS cases, in cycle regulation, in abnormal uterine bleeding, dysmenorrhea, and endometriosis. So in PCOS, we use it for controlling menstrual irregularity, acne, hirsutism, and body weight, and biochemically, that is, sex hormone binding globulin increases by 5-fold. And these are the national and international guidelines. This American College of Obsgyne, ESHRE, ASRM, everybody recommends it to be used in the PCOS cases. In abnormal uterine bleeding, it is the first line of treatment. The grade A level 1 evidence is there. A woman who is not desiring of conception can continue with using AUB for 6 to 12 months. Heavy menstrual bleeding similarly gives very reduced menstrual bleeding blood level. And when we compare it with the drospirenone or cyproterone acetate, no data is available. Levonorgestrel is far less qualified to use in that case. Dysmenorrhea, of course, we know is taken care of. Endometriosis, again, ESHRE recommendation of grade B has to be used. Lastly, a few newer contraceptives. Now we are also looking at the melgossipol, for a long time, extracted from cotton seed. Gonadotropin releasing hormone, though very effective, but there is marked loss of libido, so not very popular. A new one is coming up with Depo-Provera plus testosterone implants, which is used 3 monthly. Here, the loss of libido is not there. So this is under trial now. And reversible inhibition of sperm under guidance. So this is now under trial. Phase 1 and phase 2 has finished. Clean polymer gel made of SMA and DMSO is used, which partially blocks the vas. Gender user is from Indonesia, and it is the first non-hormonal male contraceptive pill. This it disrupts an enzyme in the sperm head and weakens the ability of the sperm to penetrate the ovum. Nifedipine, which is a very popular drug, is a calcium channel blocker, is being used where calcium channel in the cell membrane of the sperm is blocked. The amount of sperm, the number of sperms, their motility, everything will be good, but it will not be able to fertilize the egg. And this is very interesting thing. It will come in the market very soon. Ongoing trials are going on neem extract, papaya seed extract, olinoic acid, and retinoic receptor antagonist. In females, especially, we are looking at non-hormonal medicines and low-dose estrogen and newer progestogens. So injectables are there. You can use in the every month DMPA and estradiol or Naten and estradiol. This has already come in the market. We have started using it. Medroxyprogesterone, Depo-Provera, subcutaneously it can be given by the patient herself. And quinacrine pellets as a sclerosing agent to the tubes. Gynefix, you know. Assure has come. This is interesting. Transcervically, we can put this microcoil spring-like in both the fallopian tubes, and it gets blocked. Thank you so much for your patient hearing. I'm a bit late. Sorry for that. Thank you.
Thank you very much. I think it was a wonderful lecture. The talk is open for a few quick questions, if there are any, before I tell our chairpersons to comment. I'd like to ask you one question. Yeah. You know, when we are really going all around the world, and when I'm looking at the data, in India especially, as compared to our neighborhood, the permanent methods of contraception are more popular still than, you know, the spacing methods. What can we do to make, you know, spacing methods more popular and more acceptable? Because I think that is our biggest challenge. We are 1.35 billion strong, and we really need to take some action.
So, Jaideep, this is a very good, point you have raised, because this we have to do. Otherwise, the lecture doesn't make any sense.
Can you define that we? Yeah. That is what I want.
So we have to fight for it. See, we have shown that myths and misconceptions are the main issues where women are also getting, confused. Not only other faculty doctors, but also some gynecologists also do not advocate. So we have to now go on talking and training up the doctors, not only the gynecologists, but also the family physicians and medicine specialists, etc., so that they do not use it. This is also important. And you have to press government to talk. The government, when they worked on it, the emergency contraception, you know how did it work? They put it on the television. Other pills, they are not being allowing to be used as an advertisement. So once you put it in an advertisement in the television, you saw how on just, within a month or so, emergency contraception was so popular.
I think that's where it's very important for all of you to take this message home. Mindsets need to be changed. Strategies need to be changed, because our strategy on only educating the family physicians and doctors is not really going to work. What we have from Foxy done this year is that we are educating the nurses, the midwives, the reception staff, and so on. Because as soon as you counsel a patient, the patient goes out, talks to the nurse or somebody else, and they say, "Oh no, hormones nahi lena hai." So these are the most important things, that the support staff also needs to be educated. And I'd like to also put here on record that Foxy has made a film which is going to be launched after 10 days in the ICOG conference. Based on family planning acceptance. It's called as Gali Mein Meri Dhaak, which is like based on one real-time story of a young gynecologist. So all of you will be able to use it. I'd like to open this for comments from our chairpersons. Sir.
Now, yes, you have said very nicely about the contraception. This is what we started in the beginning in our country, particularly in India. But it the same attitude still going on, even amongst the lay public and the doctors. The question I have asked only for the reason that a patient or couple coming from urban area and the patient couple coming from the rural area, will they given the same type of contraception, or will there be a difference in the methodology of approach for advising contraception to that particular couple? Because in urban area, for the last 20 or 25 years, I have never got a patient who has asked for contraception, because I have changed my line. That's a different issue. But even as a gynecologist, very few people have come for contraception from Calcutta, from the metropolitan city. But what would be your advice, particularly when a patient is leaving a hospital and we don't get so many fifth gravida, sixth gravida nowadays, we get only second or third gravida. What would be your advice?
Sir, ideally it is a cafeteria choice. You cannot just tell that you are an urban woman, so you used it and you are from a rural background. No. It's a cafeteria choice. You have to discuss about everything. So in a government hospital or very busy outdoors, it cannot be done. So there is failure. But when we are prescribing in our private chambers, we are counseling, we have got our own counselors, the continuation rate of pills are very good. So
Will they be
counseling
able to
becomes
follow that?
again it's a vicious cycle, sir. So population explosion, less time for doctors to talk, so less continuation rate, population explosion. So that has to be broken at some point of of the circle. So that government can do with the help of Foxy, I think.
I think more than the government, I think we also have some individual responsibility as doctors and as the stakeholders. So we should be proactively counseling them. I firmly believe this. We have stopped doing that, and I don't think that's the right message to take home. We must counsel the patients, and we must have some support and counselors in place, because we sometimes are
No,
challenged with time.
what I wanted to say, Jaideep, is that in our private setup, we can talk for some time. We have got counselors who can talk. But at government setup, which is a majority of people are attending there, and a huge population is coming up from there, there cannot be any support. So if government keeps the counselors who are very dedicated, sincere, young people who know how to counsel, the result will be much better. That we can tell.
Maybe I think Roger, can you throw some light on how people are motivated to accept the pill in US?
Thank you for your presentation. And I totally agree with counseling. In the United States, there are a lot of different strategies that are at the grassroots level, because compliance and continuance are extremely important. But I think this concept of safety is the big overall arching concern, because there are all these contraceptive benefits. We talked a minute ago about 15 micrograms. There's even 10 micrograms. The lower the dose, the potential less risk, but bleeding control. So I'd like to pose to you, what do you think about non-ethinyl estradiol pills, like with natural estrogen, estradiol valerate or micronized estradiol, or estetrol, which is in clinical trials right now? What's your thought on that?
Yeah, we are looking forward to it, sir. We have not used it, a natural estrogen containing pill, but results are quite encouraging, and we are looking forward to it.
Can I ask something?
Yeah, definitely.
I was just thinking, if I was going to take a pill every day, I wouldn't have done it, as a male. So I feel it's kind of, discriminatory against a woman. So I was just thinking, because now things have changed. So why don't we push the concept, if suppose you don't have ethical issues against termination, abortion, why don't we push a concept of whenever you have sex, you just do post-coital contraception, and if you still become pregnant, you take an abortion pill, because you are exposing a woman to 10 years of medicine. I mean, I can't imagine.
But
me taking
Rishikesh,
it.
if you
I'll answer this question
calculate
for
the
you.
number,
I feel that this is
No,
because
no,
that.
no.
Listen, I have not finished. I have not finished it. This is what is happening. This is what is happening in the community, for your information now. What people are doing is they take post-coital contraception whenever they are taking it, and if they cross that, because it's not fair according to me. So I wouldn't have done it as a male.
I'll say 2 points, Jaideep.
Ratnavali, before that, because this is something very important. Rishikesh, if you get pregnant every year, you will jolly well take the pill,
So
if I explain to you well.
Those days we didn't have this kind of method. This method is now being used in the community. So why not push it?
Yes.
See,
Why not push it?
Rishikesh, emergency contraception, their indications are few. You cannot go on using it with a regular partner
We have
every
a
day.
study on that.
Yes.
Pardon, listen to me, please, one moment. If you calculate the total amount of progestin you are using in a single emergency pill, and whatever you are using throughout the month, means 21 days, then you will understand how much you are pushing. A woman is taking maybe 2 to 3 times per month, and you calculate the amount of progesterone is much, much higher when they are taking for 2 to 3 times per month. Secondly, I have seen a woman having ectopic pregnancies ruptured because she thought that I have taken the pill, I'm menstruating irregularly. And a doctor said, yes, it can happen. and it was actually an ectopic pregnancy that got disturbed. And this, if happens in a, this is in a urban setup. If it happened in a rural setup, the woman will die. Definitely will die.
We'll have a quick comment from Simona.
Dr. Akamali,
Yeah.
very nice, very comprehensive presentation, I must say. And counseling, education is the key. But I think, you have to dangle the carrot in front of the women. Motivation.
Yeah.
She has contraception control, she has cycle manipulation, cycle control. The men will excuse me, I'm not trying to sound a feminist over here. Well, and her general well-being also, anemia becomes better, increased bone mass density. So I think motivation has a very big role to play in this. And quick start, it's a concept. We need to start that in our clinics because it has a very big role to play to get these women on track.
And that's only we can do it. Yes, Dr. Mohanty?
I was just thinking that after all, the pills are nothing but is combination of estrogen, progesterone, which are the integral hormones to the woman. So altering the precision relationship between the estrogen and progesterone actually does the trick. The main concern for a contraceptive formulation has been incorporation of some amount of the minimal estrogen and minimal progesterone, which is effective. Only concern here remains is the intermenstrual bleeding. That apart, it has been very heartening to for all of us to know that it actually doesn't do any harm during the pregnancy even, because the infertility specialists will agree that we all support the pregnancy with estrogen and progesterone. But then what is required is, as everybody is conscious about the mass education, it has to be re-implemented into the society that it is so safe. Apart from the hormonal advantages, the non-hormonal advantages, they have to be pushed forward, and on individual and societal level, and on the by the FOXY and of course the government, it has to be rebuilt. The hysteria has to be rebuilt for the pill, and that will do the trick.
So, Dr. Sunawala, I'd like you to sum this up.
No, if we want to survive, especially in India, population control is an absolute necessity. The country is about 2.6% of the world's surface, and we are supporting 16% of the world population.